And we have more and more studies analyzing how these genetic tests may identify cases with this genetic cause. And this one, published in 2023, showed 23% of cases of familial ILD with some pathogenic gene variant. The other important point is the most frequent gene variants that are identified are telomere-related gene variants, and less frequently surfactant protein gene variants. It's important to know that once you have non-pathogenic gene variant, and it's a variant with insignificant role, you don't have to start all the genetic counseling. You only start the genetic counseling with pathogenic gene variants. So some family with unclassifiable or non-clear pathogenic variant, this family will be repeated in the future, the study, but at that time, it's impossible to perform genetic counseling. But in those that are pathogenic of surfactant genes and telomere-related gene mutations, we can reduce invasive procedures. We can identify subclinical ILD relatives. Around 25% of the first-degree relatives will have some type of ILD or ILA. To me, ILA in a family context is an early ILD. It's not ILA. Then we also have the clinical phenotype that may help us to suspect both types of gene disorders. And the other one is, the other point is that the therapeutic decision. In these patients, the answer to corticosteroids is worse than in patients without these abnormalities. And what about MUC5B? Is a polymorphism, is even cheaper to perform the MUC5B, but for what is useful to perform MUC5B polymorphism? Until now, it has been evaluated MUC5B as a predisposing factor for developing ILD, any type of ILD, but especially IPF, especially UIP. But when we have some subject with interstitial lung abnormalities, none in the context of family forms, none in the context of autoimmune diseases, performing a MUC5B may help us to better predict if this patient will develop an ILD or not. In terms of prognosis for the clinical practice, we have several studies analyzing the worst prognosis of telomere-related gene abnormalities and telomere dysfunction in these patients. This is one of the first from Newton and Christine Garcia, showing that in fibrotic ILDs, carrying some telomere-related gene variant, pathogenic gene variant, impact on survival independently on the type of fibrotic ILD in IPF and non-IPF patients. And in our group, we identified that those patients with telomere shortening, developing the disease earlier in time, younger than 60s, had a worse survival than the other groups of our patients with IPF. Furthermore, we identified that carrying more than one gene variant or pathogenic gene variant conferred 3-year survival than 10%. So it was even worse to have more than one telomere-related gene variant, pathogenic gene variant. Later on, it has been evaluated in fibrotic HP, in CTD-ILD, and also in unclassifiable ILDs. But anyway, not all of our ILD units have the possibility of performing genetics, but we can ask to the patient, to the subjects, if they have some familial aggregation, the family history. Only with this detail, we can identify those patients with higher probability of progressing in terms of short-term survival in IPF and also long-term in case of non-IPF fibrotic ILDs. In the perspective of the ERG, of the European Respiratory Society, in the task force, there was this narrative question 8, talking about the consideration in the screening of an index case, in the screening of the relatives of an index case. So it was suggested to perform TCT, chest-CT, pulmonary functional test, and sometimes 6-minute walking test. But the thing is that the most sensitive technology is the CT scan. The follow-up will depend on the age of the subject, the gene variant, the clinical expression, and also the entity in the index case. And as I mentioned it before, only relatives of an index case that carries pathogenic gene variants are candidates for the genetic study, not the ones in which we identify unclassifiable. When we perform the screening in these first-degree subjects and over 6 years in this study, the authors identified more than 80% of cases with subclinical ILD. They said mild ILAs or moderate ILAs, but it's subclinical ILD, indeed. Another important point for the clinical practice is that genetics is not easy. And you need a team expert in clinical genetics and also in genetic counseling, which are those two different figures. So with this multidisciplinary team, you may help the familial ILD index case with information about prognosis, treatment options, and also, as I mentioned it before, if it's a monogenic disease, with embryogenic selection in young cases. Then you stop the inheritance of the pathogenic gene variant. In asymptomatic family members with early ILD, remember that it means more than 80% of fertility relatives over 6 years, we can avoid risk factors of progression or acute exacerbation in these patients, and also performing the proper follow-up depending on the type of pathogenic gene variant. We have also data about therapeutic impact of these genetic disorders, especially for telomere-related gene variants. In terms of lung transplant, you should refer these patients earlier in time, and also in the lung transplant units, they have to have special consideration in the post-transplant protocols to avoid infections and problems with the liver, with the kidney. In terms of drugs, the antifibrotic drugs we have very limited scientific evidence, first of all. Second, from this limited evidence, we know that the safety is correct, the effect or the benefit is variable in terms of progression, and here you see a post-hoc analysis of the capacities and the ASCEND studies, looking at this red line, that is those patients with IPF and telomere shortening, and if you see the placebo arm, the prognosis was worse, but when you see the treatment arm, the effect of the treatment is quite similar than those without telomere shortening. What about non-IPF fibrotic ILDs in terms of corticosteroids? Because we know that in a post-hoc analysis of the PANTHER trial, we knew that the immunosuppression effect or the handful immunosuppression effect of the PANTHER trial was in part due to telomere shortening in IPF, but we are not using high dose of corticosteroids in IPF. However, more recently, there has been publications about the harmful effect of high dose of immunosuppression in the unclassifiable ILD and fibrotic HP. And more recently, the telomere length testing led to treatment changes in 32% of cases, reducing or avoiding immunosuppression in fibrotic ILDs. These are for the future clinical practice, because there are some clinical trials ongoing for some telomeric disorders. So we will have targeting therapies probably in the future, not now. But currently, why not to use genetics in the multidisciplinary team before the invasive procedures? It's the same than the autoimmunity or EGGs. Not always gives you a useful data, but you will do it to discharge some cause of this ILD. So maybe in the future, you will also use genetics. So my key messages for you is that genetic studies are useful now in clinical practice for monogenic ILDs and familial ILDs. We are working together with other teams in different countries, in Switzerland, in Australia, Canada, and also Belgium, for networking, trying to putting together our knowledge for translated into clinical practice worldwide. And what we need for it, this validation about the clinical utility, targeting the special subgroups of patients, and solving and answering questions and ethical gaps that, to me, are very, very tricky. Thank you very much, and I would like to thank our team of genetics as well, and the ILD team, the ILD family that met just some months ago in the iClub in Athens. Thank you.